Welcome to the OrthoPAC podcast with your hosts Sam Dyer, Chuck Dowell, and Miles Gilbreth. Please join us as we attempt to fill in the gaps between education, current events, and real-world practice.
Listeners, welcome back today, Dr. Bert. Dr. Bert's fellowship-trained orthopedic surgeon who currently practices in Arizona. He recently gave our Phoenix attendees at the Ortho in the West a lecture on hip and FAI and is here to discuss it with our panel. Dr. Bert, welcome back to the podcast.
Well, thank you for having me.
Good morning, Dr. Bert. Thanks for joining us.
Yeah, good morning.
It's interesting. I use the Baton testing quite a bit in screening for patients, especially shoulder, knee, and hips. So it's good that I'm seeing you're using that as well. Just to switch directions a little bit. So, I run an orthopedic urgent care and I see a lot of patients come in. What's your approach to young patients that present with hip pain? I think that's always a difficult thing in young providers on how to approach those patients.
So it depends on age. So if you still got a relatively skeletally immature patient that comes in with hip pain, and they feel pop kicking or running in the front of their hip, you always want to look for that apophyseal avulsion off the ASIS or AIIS. So those two are pretty common to see, especially in that younger age group that have an acute onset of pain. What I'll typically do is screen for, first get a good set of x-rays. You want to do, it's nice to get, what I like to do is AP pelvis, modified Dunn view to look for the CAM lesion, and then false profile view. And what's nice about the false profile view on a younger kid is that you get to see the AIIS and ASIS much better in profile. And then you can tell if there's an avulsion with that view. That's helpful, especially in the skeletally immature. Obviously, patients that come in that are dysplastic, you're going to be more concerned about a labral tear and something like that, or a bit large CAM lesion. And then in the older patients, you got to think of activity. So somebody comes in, they're having hip pain and they're runners, for instance, especially the females, young females that are runners, you got to make sure there's not a stress fracture. So if they have, pain in their groin, it hurts with running, they've increased their mileage recently or training for a marathon, difficulty with weight bearing, if they do the single leg hop tests where they hop on it 3 times, it's painful, the heel tap. Those are, you got to be concerned about a femoral neck fracture, stress fracture. So you got to get an MRI on those urgently, protect their weight bearing. Then you got to think of acuity as well. So you're probably in an urgent care setting, you're seeing more acute injuries. Somebody that has hip pain that is in sports, that is skeletally immature and has a sudden onset of pain, and they have groin pain, you think maybe hip flexor tendonitis, which, you get a lot of people diagnosed with hip flexor tendonitis that have groin pain that are athletes. But hip flexor tendonitis has been going on for 4, 5, 6 months and still bothering them. Then you got to be concerned that it's not just a hip flexor tendonitis, especially if somebody's rested. So, I get that all the time. Well, I've been told I have hip flexor tendonitis, and they get hip flexor tendon injections and it doesn't help, but they have an underlying labral tear because their hip's stiff and they're having continued groin pain. So that's one to consider, further imaging in somebody who's had chronic groin pain that has been diagnosed with hip flexor tendonitis. The other one is core muscle injury and, or sports hernia. So, you hear those, but that's kind of more pain kind of above the pubic symphysis, sometimes a little bit of adductor pain, the painful resisted sit-up testing. And so those are ones where you can get specific imaging on with an MRI to look, using the sports hernia protocol to look for that. That's just something to kind of consider as well.
Yeah, those are all great. I actually had a patient with an ASIS avulsion 2 days ago. So I think that acute onset is helpful. Talking about the core muscle injuries or athletic pubalgia or sports hernias you talked about, they're all, the same terminology. How do you differentiate that between like FAI in a patient? Is it just the acuity? I feel like the impingement testing hurts a lot of patients when you're checking for CAM stuff. So what's your algorithm for that?
Yeah. So that, that's a lot of it. That's physical exam findings. So when you look at core muscle injury, first off, location. So it is, I guess there's some overlap there because you have that adductor pain, right? And that's kind of down in the groin area. And then you have the rectus abdominis, muscle there that can get a little tear in it as well. And then that can cause pain above the pubic symphysis. And then that also can be close to that, inguinal crease. So then you're trying to decipher if that's coming from the joint or if that's coming from outside the joint. And so for one, you do a good exam, look at the range of motion first off, see if that right, if it's a right hip, see if that affected hip has loss of range of motion. First off, do the fader testing, which is the flexion, adduction, interrotation testing, and see if they have any impingement signs. Also look at Faber. So sometimes it's very subtle. In some patients, you don't see any changes in their range of motion, but when you do their Faber test, which is flexion, AB deduction, external rotation, and that figure 4 position, if that is higher on the affected side than the other side, then you get be concerned that maybe something intra-articular going on. If you do all that stuff and you find that they're positive fader, if their Faber is positive, they have a cam lesion, and you have an MRI that's you're going to do an MRI as well. But if that doesn't show much or it shows questionable labral tear, questionable core muscle injury, what I like to do then is an intra-articular lidocaine injection. So do a diagnostic injection under ultrasound to see if the pain goes away. And that's probably the most powerful test for you in that situation, because you'll be able to tell right away if how much the labor is contributing to the pain versus a core muscle injury. If they say I'm 80% better and I'm still have a little bit of pain outside of the hip, then it's likely a labral tear as the source of the pain.
Yeah, so using that interarticular injection for diagnostic and therapeutic purposes. You had mentioned MRI. What's the difference between the MRI? Do you get MR arthrograms on all things you're trying to rule out labrum, or do you think the 3T MRIs are good enough where you don't need the arthrogram? And then if you're getting the athletic pubalgia, is that a different MRI just of the pelvis? What's your order on that?
You'll do a pelvis MRI for core muscle injury, and they have a specific protocol. I know locally that's what I've been told. They have a specific protocol for the sports hernia where they're looking for it. I don't know if they do different sequences for that. For the labrum, you do get a dedicated hip MRI. Now, I don't use MR arthrograms as frequently as I used to because the imaging has gotten better at picking up labral tears. I think the indications for a MR arthrogram would be more in a revision setting, for one, because you're looking at a few things. You're looking for capsular integrity. You're looking at the labrum. You also, if I had a surgery in there, there's a lot of scar tissue. So it's harder to differentiate a labral tear from scar tissue when you don't have the arthrogram. The other indication is if you do have a negative MRI, so the MRI is normal and you have a high suspicion for a labral tear, you can do an arthrogram. In most situations, I typically just do a lidocaine injection just to see if the pain gets better than just to confirm that there's something, some sort of intra-articular process. But typically, I just do a regular MRI unless it's a revision setting. Sometimes you do see patients who don't really have much of a cam lesion or have a pincer lesion, and you want to confirm it, you can do an arthrogram. But typically patients with standard or large cams, you can just do a standard 3T MRI and you should be able to pick it up.
Nice. And last question. So you'd mentioned injections. I know there's some recent kind of increased documentation on rapid progression OA after some injections. A recent conference, some of the joint docs were saying they're not doing as many interarticular hip injections because of this. What are your thoughts on this? Has this changed kind of what you've done? I've always been hesitant to do IA injections in young, patients.
I think what the trend is going towards is PRP. I think you have a lot more physicians now doing PRP in patients just to preserve the joint, especially younger patients. I think when you get no patients in their 50s who already have some mild chondral changes, you'd be less concerned about it. But you have a young patient has a labral tear with a preserved chondral surface. If they're in-season athlete and they're trying to get through the next couple months of football, I will offer them a one-time cortisone injection, and that will be 1 cc of 40 milligrams of Kenalog with about 3 cc's of lidocaine. And that is a one-time offer. I do not do that repeatedly. I think in patients like that, just to get them through the season and then with the intention to fix the labrum after the season is concluded. I do offer PRP as well, but when you consider PRP versus cortisone, you have to keep in mind that PRP does take time to work. So that's not instantaneous reduction in inflammation. That typically takes about 3 weeks to get better. So if you're considering injecting athletes, you got to let them know, because if they want instantaneous relief so they can get back as quick as they can, then I think a small dose of Kenalog with younger patients is fine, with the understanding that there will only be one shot. You're not going to give repeated injections. Older patients that are maybe in their 50s that have labral pathology with some underlying chondromalacia, I'm not as stringent about that. But I do discuss with them, if they continue to get cortisone injections repeatedly, that is something where you may consider not fixing the labrum in the future if you're going down that pathway. So when you decide to keep on getting a cortisone injection, we are degenerating the joint, and you warn the patient ahead of time.
I have a follow-up question on that. So I've talked about this a couple of times, and I do them not in the hip, but What would be your thoughts on an IA, Toradol injection as opposed to PRP or corticosteroid? More cost-effective, less caustic to the joint surface.
It's funny. I don't have any experience doing that. I know a couple of my partners have tried it a few times. I don't know the literature on that. I've heard that used before as an option over cortisone. I personally don't have any experience with Toradol in the joint. I know some athletes have tried that, and I think it's pretty effective. I just don't know the longevity of that injection.
Yeah, unfortunately, most of the research is coming out of Europe, and they're mixing it with bicarb, and I think they might have even been putting HA in with it too. So it's not a very well controlled studies that I've seen, but personal experience for patients has been mixed. Some great, some not great. But yeah, just a thought.
Listeners, stay tuned to next week when we follow up our discussion of hip arthroscopy and pathology with Dr. Bert. Thank you for joining the OrthoPAC podcast. We also welcome you to visit our website, paos.org, where members can download virtual conference content and get Category 1 CME. Also, if you're a non-member and you're interested in our CME content, please visit the aapa.org Learning Central for the PAOS virtual content.